I'm in control now. See, I'm on lamotrigine, and at the time of the story, carbamazepine as well. And I was thinking about having a child. And I had to really think carefully. Actually, after doing some pretty basic research, not about whether to have a child or not, because I decided to play the odds that my child would be okay. But, whether I should stay on meds or not during it. And I decided to, which is the current view, what you should do. And it took me a lot to understand also that I need higher dosages and deal with the issues that many of you have. I'm happy to report that my son is a healthy 22-year-old who's just graduating from college. He's a happy life. He's had his own challenges, ADHD, but he's risen above them, much as you all are rising above your challenges with epilepsy. I also, regarding this, I do want to give a shout out to Dr. Andy Cole from Mass General. I was a mother late in life, and so he assumed I was done with the potential of having children. He saw me in the emergency room at Mass General, was about to put me on Depakote, happened to notice that I'd seen a specialist in high-risk pregnancies and said, oh my God, stop. Thankfully, I had a doctor who was so in tune with it. I went on carbamazepine instead of Depakote, much lower risk birth defects. And so I just have to give him a shout out, as I do think of him practically every day. I'm grateful. So, all these decisions, of course, mine are very personal ones. Some people decide just not to have children because that's what's right for them. So, but Anthony does hope that you'll be leaving today with even more information to make your own decisions. There are people here today that make it possible for us to come together. And I want to give special acknowledgement to our sponsors today who make such a difference in our being able to hold events like this. So hopefully you had a chance to see some of them and talk, but in case you haven't, there's UCB, Jazz, Sumitomo Pharma, which used to be Synovian, in case you're not familiar with it, SK Life Sciences, and Neurelis. And also I want to mention our very highly respected, we're really lucky to have them, presenters today. So we have actually a pretty big contingent from Brigham. And so Dr. Vanescu, Deepa Panus, who's a PA, and Dr. Reagan Lemley are all from the Brigham, and I can't wait to hear them. Also from Boston Medical Center is Dr. Abra Al-Faraj. And then, as I've already given her, welcome to Dr. Lydia Mora from Mass General. So I expect to learn a lot today, and but enough for me. Let's hear what the presenters have to say. Thank you for coming.
Hi, everyone. We did a little bit here. I decided to not bring slides, not give a talk, and to be here present, answer questions, and really not make it look like a presentation. Even though my mom has been always trying to force me to use jackets, I felt that today's Saturday, I don't really need that. And why she did that? It's because, she comes from, and I'm going to go a little bit off topic, Christine. I'm sorry. But I do have a few minutes. So I come from Brazil, as you can see from my accent. And, back in Brazil, we suffer a lot from stigma on multiple things. And that's one of those that I was like, looking at my jackets, like, why do I have jackets on a Saturday? And that is, from from being young, I thought that I needed to really do 3 times more than my counterpart male to be recognized 10%. And then I remember that, when I was the woman younger of, I had 3 older brothers. And then basically the whole idea was that, my brother school, and then the idea is that they would have a profession and then they would raise a family, and I needed to get in and learn how to cook and clean and do those things. And my mom was very wild. She decided back in Brazil that she said, look, I want you to study just like your brothers, and I want you to be whatever you want. And I'm going to treat every person that I'm raising as if they have no gender. So that was my first learning about that. Sometimes these gender labels, they sometimes put some boundaries on what our potential, what we can do or be in our lives. So every time I can recognize stigma, I can recognize a boundary or something, I'm really going above and beyond to break that. So what I'm doing, what my goal for today here is to actually empower you with some knowledge about AI, because everybody's talking about out there. So I want to be here to answer any questions. Any questions, fair game, about AI, large language models, and I'm going to give a big picture overview of what is that, okay? And before I do that, I just want to say, why I'm here as well, and not, with my family on a Saturday afternoon, it's because I truly, truly love the work of EF and EF and the community. Because I am a part of the community too, right? So I also know, and some people know that many in my family, they have epilepsy, and some are having tractable epilepsy. And I remember being 8 years old, playing with my cousin, and the next thing I know, family was hiding him from me. And I was like, what is happening to him? That he's sleeping all the time. They were giving him phenobarbital. And I was, but back in Brazil, there was a lot of stigma. Again, they were like, they really wanted to him as if having epilepsy was different than having ADHD or any other chronic condition. And I was just fascinated by why should there be so much stigma in a condition that is so prevalent, so common, and why there should be stigma at all in any condition, right? Everybody is different, everybody should be embraced, and everybody should even receive more and be more embraced. So from that moment on, I wanted to have my cousin play with us just as before, and then I wanted to be with him, and I wanted him to have the same potential as I had from the very beginning. So yes, I'm part of the community. And why technology? I'm going to give you a few stories from back then, and why I'm so fascinated with AI. So when I was a resident, basically you do med school, you study, and then you do residency, which is basically becoming a subspecialized person, and then you do neurology. And neurology was what I wanted to do, because that was my path to become a specialist, figure out how to stop seizures from very young. And then I was a resident, I was a chief resident. I was responsible for taking care of everybody that was coming to the hospital at night. And then there was this, again, 8-year-old kid coming and status epilepticus. Everybody knows like seizures back to back. And then the junior resident came to me and said, "You don't have adult size 2. We don't have kid size 2. You're going to have to intubate him with an adult size 2. I was like, how come? And it's like, yes, we run out of materials, and then we couldn't, we don't have a system to flag when the materials are running out. And we didn't, and the purchase order went out, and then it's going to come in a few days. We might borrow from another hostel, but by the time it comes, it's going to be too late. And then I saw this mom looking at me, and she said, please help us. And I had no option but to do our best. And long story short, this kid who was playing video games a week later, very happy with a sore throat, but I was determined to understand why everybody don't get the same level of quality. Why don't everybody get access to the services they need at the time that they need? And why there are, people in the US sending humans to the moon, and here we don't have a way of knowing when a tube is running out of store. So that's my whole journey. I really want to fight for access, equality, and quality of care for people living with epilepsy. And why AI? And what is AI, right? So AI, it is basically when you use computer programs to do tests that look like they're trying to mimic what humans do. So if you go to, I'm going to give you one story about Target. So I'm getting comfortable. So, fast forward, I was a fellow. I wasn't a fellow, Emma was a resident. So Emma is super back there. You're going to hear more stories from Emma. But I was a fellow in epilepsy at the Mass General, and I was very busy, super busy. And I also was, again, this Brazilian person that, the whole family was pressuring me for having a family. And I also wanted to pursue my dreams of changing my career. So there's always this balance, right? So what I decided to do is I'm just going to follow my dreams. There was this day, I was very, very nauseated, very tired. And then I had 18 EEGs to read in the long-term monitoring unit. And I was like, oh my God, it's wrong. I called my friend. I said, look, can you cover for me? Can you read those EEGs for me? And then Deidre, she said, yes, of course, I'm going to go. And she went, she was covering for me, but I was like, I'm not going to let her work alone. I'm going to do as much as I can as well. But I decided to pass by Target. So I passed by Target. I said, I think I might be pregnant. I'm going to get a pregnancy test. Then I got the pregnancy test, and then I ran to MGH. I worked at MGH the entire day. At night, I came back home, and my husband, and I didn't do the pregnancy test, it was still in my purse. My husband looked at me and he said, are you pregnant? And then I said, oh, why would you be asking me that? I didn't even see you today. And then he said, like in the afternoon, I started to get emails from registries, baby registries, emails, people telling me, diapers and things like that. And that has never happened to me before. And that is the power of data, power of artificial intelligence. So on those stores, they were sharing the data about my credit card to companies, to registries, and etc. And they were able to tell that this lady with this credit card that is associated with that email is likely going to make a pregnancy test. That person has a likelihood of being positive because that person is test. And that likelihood of being pregnant brings the likelihood of wanting to buy diapers. So let's sell diapers to that person. That is machine probabilities predicting what could happen and tailoring their services and their efforts to a specific population. Why I'm giving that story? It is because, number one, this is how other industries are doing way better than healthcare. For example, if there was a system like that in other healthcare systems, many things would have been solved because we could predict shortages much better, right? The other thing is, that day, I had to walk in and out to the Mass Pioneer which is another building outside MGH, to beg someone to burn a CD with an EEG data for me to read because they couldn't share the data from that building to my system. So I was like, why? I see so many patients that they come and they swear that they have asked their old doctor to send me the data. Nothing comes, right? Why the data is so siloed? Why all of the information is so fragmented and then I can't really get what I need at the time that I need healthcare? But my husband gets the news that I'm pregnant before I even get to know that I'm pregnant. And by the way, I was pregnant, so Target knew ahead of us, and they were already well prepared for what was coming. So that is the power of information technology, of using data to predict what can come, to inform, to tailor services. And how many, if you have done anything that is that the supply is short or it's finite, you probably would wonder if there could be a way of streamlining, right? So how can I save money? How can I save energy? How can I save time? And how can I make things safer, right? Artificial intelligence. So artificial intelligence is basically computer programs. They are like a lot about rules, right? So if this happens A, then do B. If this happens B, then do C. And that is like the most simple version of what computers program are doing, right? So on the back end, those programmers, they started to write code that is basically trying to mimic how the brain works. And the brain works not saying yes or no. The brain works like yes or no, but I'm putting some context to that, okay? So for example, I'm going to tell you the cat story and the stroke. So there is, this person is very alone, and then this person has a cat. That cat is a company for that person, right? And that cat has been the friend and the son and everything for that person. One day that person has a stroke. And then that person goes to the hospital. And then the hospital teams wants to get them in, to get them to sleep in the hospital because they need care. That person wanted to go home. And then nobody could understand why that person wanted to go home. Until someone came there, it's like, why do you want to go home? Your probability to die is higher if you go home now than if I bring you here. And that's like a computer thinking, right? But then a human has emotion, has gratitude, has a lot of things in context, right? So that human was saying, this cat is my life. And if I don't go home and feed my cat's gonna die. I don't care if I'm gonna survive. So a computer is not just, in the past, a computer would just say yes or no. Right now, these very advanced computer programs are trying to embed sentiment, context, and many other things in the past history to then produce an output. So that's why it's looking like humans. It's becoming more like human. So that's about AI. And then a large language model, what is that, large language models? It is because computer programs, they would just spit out their probabilities, bunch of numbers, right? And those numbers nobody really can read or understand, just computer people. But then what they decided to do is just create something that basically translates into human language. So on the back end, when you talk to ChatGPT or when you talk to Google or other softwares, it's basically like still a bunch of numbers, but they're translating those numbers into language. And that evolved, and it continues to evolve. Are you afraid of AI? And then, people say, like, I don't trust AI. But then if you actually think about the last time you took a flight, so has anybody been on a plane? Okay, you have been under the control of an AI system. Because, yes, to take off and then to land, lots of AI programs are actually running, actually the opposite. It's like to take off and to land, a human is taking over the control. But then when they are in a flat, the human, they need to rest, and it's safer to let the computer take over. And then the computer takes better to make the flight safer. So you have been under the control of AI for many of the things that you use. And why these industries, they let them do it, it is because it's either improving safety, like airplanes, or it's because it's improving efficiency. And that's a necessary thing, right? So many people are afraid of embracing that, but in one way, I can tell you, 15 years ago, I was instructed to never put something of value in my luggage because my luggage in a flight was high, right? Today, you still lose your luggage, but it's less likely, right? Because there is an AI system that's tracking where those luggages are going, and then they're predicting where is the best way to distribute these luggages as you are taking your flight. So we're letting many things help our life and improve our quality of life. How about healthcare? A lot of things could go wrong in healthcare, right? A lot of things are going wrong in healthcare right now. And I want to mention one big thing that I feel and happens a lot is, when you send a message to your healthcare provider and you don't get the answer that you need on time, that's frustrating, right? So I was, the other day I got strep throat for my kid, and that pain was awful. And then I couldn't really get PCP appointment, fever. I couldn't really get pain. I was taking Advil after Advil, and I was like, oh my God, this is awful. And then I ended up getting into urgent care. Urgent care gave me pads that said that it's strep throat. And then I knew that for me to get better, I needed an antibiotic. They gave me an appointment with the PCP in 3 weeks. I was like, I'm going to die. And the other thing that they going to call you, but in 3 minutes doesn't call you, in 20 minutes call again. And I was like, 20 minutes in, I was in pain and no call back. 4 hours in, and I was like, nobody's calling me back. And I was like, oh my God, I would never, ever in 5 minutes to call someone back. And then I was very, very frustrated that day. And in two ways, because I knew that I knew what I needed, and I knew that time mattered, and I was suffering. I ended up getting my antibiotic because the nurse called me within 6 hours to give my antibiotic. But the flip side of that is, next day I'm sitting on on the other side of the table, and the nurses they said, look, we are humans, we are tired, and we don't know how to handle a volume of 300 messages a day with this amount of people. They are working day and night, and they don't know how they can safely address all of these needs because it's too much for a human being. And that's, again, an efficiency thing, a safety thing, right? A volume. And that's how AI can shine, because AI can read those messages and at least classify which ones are prioritization, which ones are medication renewal, and which ones are someone in pain waiting for an answer, or someone with a positive test that needs an action. And then the prioritization that is not going to happen after 4 o'clock because nobody's going to pick up the phone, can wait for the next morning. But then that person in pain needs a call back within minutes. So triage, organizing systems, making systems more efficient and therefore safer is one of the applications of AI that I have been very enthusiastic about. what is the downside? The downside is that with every new technology, with every new thing that can go to the market, especially in healthcare, there are risks as well, right? And I think, people have been talking about what if it makes a mistake? What if it classifies something that was supposed to be called within 2 minutes as a prior authorization wrongly? My answer to that is this is indeed a possibility, a calculated possibility that you can measure based on each program that you are testing. But what is the alternative? The alternative is letting nurses that are burned out try to screen through 300 messages every day and then try each one of them with their own way, try to address one by one. So the alternative has been also a challenge, right? So if you calculate the risks, you might make decisions one way or the other. What is the most scary thing that I find on these AI systems? Bias. It could make it worse, right? So I'm going to tell you one thing that I noticed 10 years ago. There was a friend of mine. She was a kidney doctor, and she was very, very worried about some systems, some algorithms that they were allocating people that they were in need of having a kidney transplant to kidney transplant. And they were basically, because the system was trained in using data that would preferentially, historically, give kidneys to wealthy people, blind people. And then the black people in the waiting area for a kidney, they would not get, because they were using a piece of information that would put them at the end of the line. And then she was able to prove that this system was biased. And then this system had been upgraded so that equity in access to kidney transplant has been improved. So, and that was basically an algorithm. Today, AI is also an algorithm, but it's more complicated to uncover the inequities. It is a black box sometimes. Many people that are buying those and using that they cannot even see. So we need people that care about disparities, inequities, gender, race, all kinds of biases and inequities to be looking at that and to say, this is wrong and this is why, and that's why this product is better than that product. And that's why I am finding courage to sit in tables where there are a lot of people that they don't look like me. And that's why I'm finding courage to say, I am an AI expert because I am an equity, access, stigma expert. And because I am one of those, I am really, really pushing hard to bring that awareness to the tech guys. And why did I say tech guys? Because I'm here to really share that you all can be experts. And I will tell you my last story. And it was supposed to be just questions, right? I'm just telling you my story. But that's the last story. The last story is about Diego. I need to talk about Diego, right? Diego is my second child. One day, someone from the American Canal of Neurology asked me, Lydia, can you write a paper? And it, by the way, it was published yesterday. Can you write a paper about AI applications in clinical practice? And then I took a pause and I went home. And I was going to say no because I said I'm not really an AI expert. I didn't feel like it. I don't work at Microsoft or AWS or I can say I'm an epilepsy doctor. And Diego, and I said Diego, ChatGPT 4. Here is it. I want you to evaluate and tell me what you think of it. And then he asked ChatGPT 4 and said look, I want you to make a picture of a fox, a lion, a dragon, and a cat playing Uno. And then ChatGPT 4 spitted out that picture. And then Diego looked at that and is like, Mommy, this is really good at making shapes of regular animals, but it's not good at displaying the cards of Uno because the cards are wrong And also, it's not really good at understanding the rules of Bruno because this person is behind that person and that person is not supposed to see their cards. And I look at it, Diego was like, oh my God, he can evaluate a large language model. And he can evaluate and not only tell me ways in which it's good and also tell me ways in which it can be improved. And then I came back and said, like, yes, I can be, an AI expert and a paper because I know as a cousin of someone living with epilepsy, as a physician coming from an underserved area, as someone that has suffered stigma, as someone that has suffered issues and has been trying to fix issues with access to care, I know how to evaluate those systems and tell in which ways they can work, in which ways they can make it worse. So that's how I feel that you can be experts. If you use any technology, look at the output, make a prediction of what would you expect for that thing to tell you, right? Don't trust that immediately, okay? It might have mistakes, it might have errors, but voice out what could that thing, that output, do for you that could be better, okay? So I think with that, I want to open up for questions that you might have on any topic. And I think I might be out of time, right, Emma? I need the microphone.
I have a question about AI and how can we keep data safe with the hackers? They hack so much throughout the world, and so how can we keep it safe?
Yes, this is a great question. How can we keep our information safe and hackers? And I can is huge and billionaire, right? So people in that they really know how to crack systems. They are really making a fortune because they access information, and then who owns that information sometimes is willing to pay big money to get that safe again because of lawsuits and things like that, right? And among the cases of hacking over the last year or so, I have seen a paper that showed that they're really targeting healthcare. So it's one of the big targets because, in one way, it's where a lot of sensitive information is sitting. Governance systems and data safety and protection systems are in place. There are multiple guidelines, and the FDA is now creating new committees for vetting and evaluating new AI systems, the new devices, to say, this one is compliant with these guidelines, and those ones are not. So, for example, in your in your case, as I'm gonna be a consumer. I would advise you to, for example, I want to get an app that is going to help me track my seizures. Try to use apps that are recommended by FDA, by YAG, or anybody that could endorse that, not just like Google, because then you might not know whether that is trustworthy and what you're going to do with that data. Also, read the cookies, right? So the cookies, what's a cookie? It is like every website, there's like a pop-up, and this pop-up makes you click down, right? The moment you click down, you're basically accepting it. So the cookies are basically pop-up messages that are basically telling you what you're going to do with your data. And if you hit OK, accept, they might just be getting your authorization to use your data, and they might sell your data, they might do many things with your data, right? So read the cookies and accept what you are willing to accept, or just don't accept. You can modify, right? So every website you go, every app, read the cookies. Consent. AI is now actually being used to, if you want to be a part of a clinical trial or anything that is required to get your consent, now AI is being used to basically change the level of the language to any translation, to any level of language, so that the person that can read, understand, and accept or not. And then the other thing about data safety and I would say transparency. It is, it's about, even when you believe that you put information that is not going to be identifiable, those systems are so smart that they store that. And then 3 weeks later, you put another piece of information, they store that. 3 weeks later, they put another piece of information on the back end. Those models, they're putting all of them together and making a story about you. So it can even re-identify. For example, in healthcare institutions, no healthcare provider is allowed to put any information of patients into those marketed inside of the system. This part is equities. People say like, oh, this is going to go to a cloud, the web, right? ChatGPT and all of those things go to this cloud, and then you feel like you are out of control of that, and that might make people unsafe. So the next generation of iPhones and other smartphones are going to have the ChatGPT 4 and the other forms of models without the need of internet. It is inside the phone. But then where the part is there, right? What is the inequities? This new generation of phones, they're going to be super expensive, and they're smartphones. How about people that they continue to not have money to buy those kinds of phones? How about the people that do not have generation of the Apple iPhone? What about the people that are not even with access to internet? The disparities gap is going to increase, right? So the people that are wealthy that can buy the next generation of iPhone, they're going to have the most safe and most secure form of accessing those systems. And then the people that they are in those marginalized areas, they are more marginalized. It's kind of bittersweet to realize that AI can make so good for efficiency and safety and help humans make less mistakes. It's also scary to see so many ways in which it can exclude more and more people from the future. And we have a duty to raise those questions, to keep talking about that. And if we don't, then nobody's. I think I'm gonna, take questions separately because Emma has a lot to talk about. And this is not about technology; it's about women's health, menopause, hormones, and all of that. And by the way, every time someone comes to me and say, "I'm thinking about getting pregnant," I say, like, "Go see Emma." That's my. Please.
Want to let everyone know that when you leave, we do have flowers for all our guests, so please make sure you get one inside of it. Make sure you have batteries.
And I'm also next to my position from women. Chapters in helping women with epilepsy to go live from young adults all the way to menopause. And my focus has been pregnancy and epilepsy as the not only me doing that work. I'm lucky to have Regan Lemley, Dr. Lemley is with me at Brigham, and she's fantastic. I was so happy when she decided to stay on with her fellowship because I really would not be able to do it at all without her. And we have Dr. Abrar Al-Faraj here from Boston Medical Center. He was work over there. And we were also supposed to have Dr. Trudy Israel, and she's not here. She couldn't be here, unfortunately, today. But I feel I'm lucky that I have a group of friends, and we are all working to hopefully advance the way we care for women today and in the future. And more recently, Deepa joined the Brigham and Women's Hospital and our epilepsy division, and we've been trying to get her on our side and do more work with us. And she's going to be our moderator today. I had a patient join me for a presentation, and I thought that really worked well. So rather than making presentations today, we thought we would just have a discussion and make sure that your questions are answered. And just to start that discussion, patients like you who came to us with different problems, and we'll start talking a little bit about what questions may arise from those cases, and at the end we'll pause before moving to the next to give you the chance to ask the questions we may not have addressed. And epilepsy is so different and so heterogeneous. Different people have different types of seizures, different severities, and do make us pause for your questions when you have one. With that, let's be take on.
The way I did this presentation is just like the different stages in a woman's life. So we're going to start off with puberty, hormone, and pregnancy, and then menopause. And after each section, we're going to have some final takeaways and questions that the doctors with. So I'll start off with the first stages. So it's a 35-year-old pregnant woman with treatment-resistant epilepsy and vocal unaware with tonic to tonic seizures. Presenting from hall visit, she began having seizures at Menard, age 13 years old. She had on average 2 to 4 vocal unaware seizures per month, which tend to cluster around her menstrual cycle, 2 to 3 days before her period. She had tubal ligation. She is on Berbetracetone, 100 milligrams twice a day, and Clozamide 200 milligrams twice a day. Question 1: do sex hormones have an effect on seizure?
This is a question that it reflects what is the difference between a male and a female in terms of their epilepsy. And we know now that sex hormones, that specifically estrogen and progesterone, do influence epilepsy in women differently. Where we have basic science that tell us, estrogen, for example, has a proconvulsant or can have a propensity to cause seizures, while estrogen has a little bit more protective effect. So in the women, when they enter their menstrual cycle or their menarche, some patients start to experience the change in their seizure frequency in relation to the change in these hormones throughout their menstrual cycle. So yes, the patient have noticed that their seizures tend to cluster around their menstrual cycle. That is a real true phenomenon. And it's more evident in patients who have drug-resistant epilepsy, where they overall have uncontrolled seizures, and then they're able to pick up a pattern that clusters around their menstrual cycle. So
definitely the change in estrogen and progesterone can have an influence on the seizure frequency. So there are different types in this pattern. We'll, discuss a little bit more about that, but there are some that cluster around, the pre-ovulatory, perimenstrual, and some kind of throughout during the whole menstrual cycle. And each of these sites can have a different underlying pathophysiology in terms of the fluctuation or the ratio between each of the estrogen and progesterone hormones.
Question about epilepsy is not to show that there is an exacerbation of seizures around certain times during the month. So that, like Aurora mentioned before, and you saw that nice graph, maybe we can go back to it, Deepa. There are hormones that fluctuate on an approximately month. And you can see that they go up and down, and it's supposed to be at those inflection points where there's changes from high concentrations to low concentrations of these hormones that trigger epilepsy. And the exact mechanism of how that happens is still a lot of research going on, and we don't understand to the point where many times I have patients asking me, should we check hormonal levels? It won't be helpful. It's not an absolute number, an absolute concentration you're looking for to determine whether those sex hormones are likely to influence or not the seizure frequency at certain times in the month. We just know that those fluctuations at certain times of the month may trigger seizures. And as Aurora mentioned, the ones around menstruations are the most easy to detect, and that's what we call perimenstrual, or there's an older study by Dr. Herzog who really established the definition of catamenial epilepsy, calling it C1. So you may see in some publications or online C1 or perimenstruation. That's one pattern of catamenial epilepsy. But patients who are likely to have seizures around menstruation may also be likely to have seizures around ovulation. As you see in the middle of the cycle, there's again a bunch of shifts in these sex hormone concentrations. So there are patients who have seizures around ovulation. They have a C2 or peri-ovulatory pattern. And a recent study looking at a bunch of patients with catamenial epilepsy was able to show that actually the one. And sometimes patients are good to detect that pattern themselves, to say, yes, for sure, I noticed the. But sometimes they're not, because they may one cycle a seizure around menstruation, another cycle a seizure around ovulation. They may not follow their ovulation. It's hard really to tease apart things without making an accurate seizure and menstruation diary. So what I usually do when patients have this question for me, I ask them to keep a calendar of the first day of the to accurately determine if there's indeed more seizures. And the definition is that you should have around those times of the month twice as many seizures as at other times. Now that's just a definition. Whether other people who have less than twofold would not benefit from the same strategies that we apply to Neurelis catamenial epilepsy. Not many personalized treatment for the strategies that we developed. And I'm going to stop here so that I give the opportunity for others to talk.
Treated differently? I would say yes and no. The mainstay treatment is still with seizure medication. There are some studies that looked into certain types of medications. These are much smaller studies, but there's specifically a lot of focus on using progesterone. As I mentioned earlier, progesterone has protective properties, and they said, why don't we try and see if we can use that hormone to treat those patients who have that imbalance in their estrogen and progesterone hormones. And the initial information was very, supportive of this, using progesterone in a cyclical pattern to see if there is improvement in seizure frequency. And the data was positive, but then when they replicated on a bigger scale of study, they found that there was really no difference. However, there was those patients who had the perimenstrual type, which was attributed in the pathophysiology of the drop in progesterone. They found that these are possibly patients that may benefit from progesterone replacement. Still, the data is really not strong. There's a lot of variability in terms of the dose, the frequency, how to use it exactly is still an area of ongoing studies. But in general, the mainstay treatment still remains to be with seizure medications, and then there could be different trials, depending on the response to the modification in seizure medication, or even in combination with medication modification as well as progesterone so far.
So as you were saying, you still treat this like any other epilepsy, so the main treatment is the your antihistamine medication. But some people have found, if they have a perimenstrual pattern where they predictably always have there's around menstruation time, sometimes they may have an extra anti-seizure medication in the answer, but that definitely requires having a very predictable cycle to do something like that in advance. And then, we do work in conjunction with some of our OBGYN colleagues to work on potential hormone options, birth control type options, which can also help. So that's not typically the first step. The first step is definitely our anti-seizure meds. Good results for getting like that. And we should say, because we work with our OB team, obviously at Program, we also work with that to go back to. So sometimes we refer patients over to the digital.
Sometimes seizures may cluster independent of the hormonal fluctuation, but when there's clustering that matches the hormonal fluctuations, when we have a suspicion for this catamenial pattern, then it may be useful for some patients to try hormonal suppression, like Dr. Glenley was saying. We may use certain forms of hormonal perception or hormonal supplementation that's used for other OBGYN colleagues to suppress that hormonal fluctuation in the month. And sometimes that's helpful. It doesn't work for everyone. It works more so for those catamenial epilepsy patients. But one thing to mention is that these hormonal supplementations come in different and flavors, and they have different dosages of the sex hormones in them. So you basically take sex hormones
concentrations of your endogenous sex hormones. Hormonal supplementations don't work as well in patients who are on medications that we call enzyme-reducing medications. So some of the medications like carbamazepine, phenytoin, phenobarbital, but even oxcarbazepine, topiramate, Ompi, are medications that enhance the hepatic metabolism of sex hormones. So some of those contraceptives may not do the job that we hope they're doing in these patients, and there's specific that may be used when it's thought that sex hormones may play a role in the fluctuations in seizure frequency throughout the month.
When I was having my seizures, I did find that the week to 10 days before my period, my seizures were bad. I could go 2-3 weeks. I had complex partial seizures, and I could go 2-3 weeks with not having any seizures, and then all of a sudden I have a day where I have 2-3 seizures in a day, and I kept a calendar. And if somebody saw them, they would comment or initial or anything, and then my period would come, and I get through my period, and then I would fine for the next 3 weeks until right before again.
You know exactly how common epilepsy is specifically.
Yeah. I did have successful surgery. And since, we have had it, but, it happened.
Then I can ask it out. So say a number to correct me if I'm wrong, but if you can see that even as many as like
2% is out of that. And a lot of those are very mental, very ovulatory. So that people always may have studies around ovulation, then we can help.
A 5-year-old woman with juvenile myoclonic epilepsy, well controlled on lamotrigine 150 milligrams twice a day. She presents with a cluster of seizures after being well controlled for over 5 years. She has been experiencing frequent morning myoclonic jerks and most recently two bilateral tonic-to-clonic seizures. She denies any provoking factors. However, she recently got married and was prescribed oral contraceptives by her PCP. So question is, this question I believe goes to Dr. Yeah. So, does contraception and anti-seizure medication interact with each other? If yes, how?
Take this. So the medication generally, whenever you're prescribed a new medication, the first question is this: is it going to interact with my seizure medications? And the answer to this is that yes, but for some type of seizure medications and some type of contraception. So I think before we get into the details of that is that we first have to categorize medications and categorize the types of contraceptions. Hormonal contraceptions are of the focus in this slide here. We have the non-hormonal ones, which is the condom, the copper IUD. These generally do not interact with seizure medications. While on the other hand, when you talk about hormonal contraceptions, they come in different forms, in different hormonal concentrations, and these are usually do interact with seizure medications. The seizure medications that usually have that type of interaction is what we call enzyme-inducing seizure medication, like Dilantin, phenobarbital, topiramate, clobazam, oxcarbazepine, and these tend to have a bidirectional interactions with a lot of the hormonal contraceptions. The most data we have is about combined oral contraceptives, where the effectiveness of these birth control can be reduced by a lot of the enzyme-inducing anti-seizure medication, which can make the birth control ineffective and obviously the risk of unplanned pregnancies. So here we tap on, as I said, there is bidirectional interactions where the seizure medication can make birth control ineffective and vice versa. Sometimes the birth control can make your seizure medication ineffective. The most common medication that is affected by this type of interaction is lamotrigine. Just in our case here, where this patient was on lamotrigine, was started on birth control, and then all of a sudden she started to have breakthrough seizures. And that's the first alarm that could this be due to medication interactions. And that's why I always tell my patients that once you are, at reproductive age, just be a step ahead of time and think about birth control if you're not planning a pregnancy, and is this going to be a reasonable option for her needs, and also is it going to interact with the seizure medication. So overall, I think, my takeaway message here is that first, that hormones do influence seizures, seizure frequency. As we said, the mainstay treatment is still with seizure medication. There are certain types of interventions that can be done. Definitely, this is a question to discuss with your neurologist. Birth control, having contraception. Family planning is very important for women in epilepsy. It's always recommended if you're not planning a pregnancy. The choice of the medication should always be a discussion between you, your neurologist, and definitely involve the complex family planning gynecologist that can help you make a decision about what is the most appropriate contraception and also safe for the seizure medications.
So next topic is sexual health and epilepsy.
I'll just, while we figure out the computer, I'll just share a very brief story that just came up for one of my patients this week, in talking about how the contraception can affect seizure medication. So one of my patients is on a somewhat higher dose of lamotrigine, but overall she feels good on it. It works for her. But she changed her birth control. She was taking some stuff continuously, then she kind of switched off and started taking that placebo week. And she started to not feel so great in that placebo week. Because if we think about it, the birth control pills that contain estrogen, they can lower that lamotrigine dose a little bit. And so when she started taking placebo and no longer had that interaction during that, her lamotrigine got a bit too high and made her not feel so good during that. So that's important to think about. Those kinds of interactions, they can definitely feel odd, not after the pill week. So overall, we're just rechecking levels and we're going to bring her down a little bit. Well, it could be something I could. And on the flip side, we could have a different conversation, say, hey, we can just go back to taking the birth control continuously and just avoid that whole higher level situation. So there's kind of two ways to, obviously, her preference is what we're going to end up doing. But that's just one thing that can definitely happen.
By basically trying to give it to the brain or mind. I think this applies not only to contraception, but to going back to contraception, what I wanted to emphasize is that you have a lot of choice. You shouldn't just accept the choice that you're presented with. There's a way to work around any contraception that you need. It's a little harder to choose a contraception when medication, as we were talking, just because the enzyme-inducing medications render some forms of hormonal contraceptions, not all forms of hormonal contraceptions, ineffective. But for people who are on medications, which are some of the newer medications, levetiracetam, lacosamide, they can choose any contraception option with lamotrigine, as Dr. Lemley was saying, there are ways to compensate by dosing it appropriately. And you have many options of contraception. I don't like when physician says, oh, just choose an IUD because that works for everybody and there's no interaction with medication. Those interactions are some of the newer medications, right? They may not be very well established, but we have an idea whether they are or not enzyme-inducing medications, and we can choose the right form of contraception. But that information is available out there. Just make sure that if it's a contraception prescribed by a gynecologist, you do mention that you're on anti-seizure medications, because they may not realize, and they may give you something that doesn't work for you. It's most often that the anti-seizure medication influences the contraception than the reverse. So a lot of women are worried that maybe if they go on a hormonal contraception, their medication levels will be altered, their seizures will be influenced. Perhaps, the exogenous sex hormones that you ingest may play a little bit of a role in seizure frequency, but that's not clearly demonstrated. As you heard, many times we use contraception as a strategy for catamenial epilepsy. But in terms of the contraception changing your medication level, that happens for lamotrigine. That's one medication, but we don't have clear data for others. Now, I should pause and say that there's a bunch of other contraception coming every day, a bunch of new anti-seizure medications, so the story may get a little more. And for example, I thought that lamotrigine is influenced by estrogen only. There's one new progestin that came out that seems to influence the level of lamotrigine. But more than that, as I said, we know about for lamotrigine only. There's influencing how effective the contraception is, but not all anti-seizure medications. So ask your physician about those interactions.
Just wanted to address, I think, because you'd asked about like some of the stuff like Midol and stuff. I think, to my knowledge, that kind of thing should not be messing with our seizure medications or kind of influencing seizures, so that should all be fine. I do wonder if women who have like a lot of the perimenstrual syndromes, like we don't have any data, but I wonder if all the symptoms are really bad, that for some people could in and of itself increase seizure likelihood if you're not feeling well, if you're not feeling good. But Midol should not be.
The next topic is sexual health and epilepsy. So the first case is a 35-year-old woman with temporal lobe epilepsy and carbamazepine has been doing fairly well in regards to her seizure control. Now only getting about one seizure every 3 to 4 months, previously once per month on lower carbamazepine dose. Over the past several months, she has noticed a decreased interest in sex and is not sure what this is from. As she has a good relationship with her partner, and there have been no major stressors or changes in her life. So the first question is, do women with epilepsy differ from the general population in regards to sexual function?
So yeah, sexual function and sexual health, tremendously complicated topic. That whole idea, your sexuality is so influenced by where you live, how old you are, how you were raised, family values, religious values. There's so much that goes into this. So it's a somewhat difficult topic for us to research, and not a lot has been done in women with epilepsy, to be quite honest. So it's challenging. There's not that many studies about it. But we do know, just in general, the general epilepsy population, there's kind of a high concurrence with epilepsy and things like depression, anxiety, and those things themselves can also influence sexuality and all those things. So that's and with epilepsy. But taking that into account, there have been a couple studies, and again, less than 10. This is not well researched. Within those studies, there seems to be an increased, or I should say, an increased number of women with epilepsy compared to the general population do complain of having like low libido or low birth. And it's again very complex on why that would be. We can get into our kind of other questions to talk about why that would be the case.
The next question is, can seizure frequency affect sexual health? That one. So again,
Can I take it?
we don't know. There are some studies suggesting that yes, there's seizure frequency influences sexual health. But what type of seizures, whether there's a different that's we presented that very paper that I'm referring to recently in our journal club. And one of our male colleagues said that is volunteer that information. And I was thinking that I only have in the past year one patient actually that to me. And I think that's part of why we know. So because there is no one focusing on that unless our patients ask those questions for us to start gathering that information and know more. We don't. There's again a few studies mostly based on, I would say, a few patients reporting their sexual dysfunction on zonisamide, for example, or on valproic. But how much, to what extent, and how that really compares to other medications, we really don't know. But it does seem like seizure frequency influences sexual function, and whether that's because those patients tend to have lower energy, perhaps comorbid depression. There are so many other factors that may be at play that I don't think we can see all seizure types do. Can certain anti-seizure medications affect sexual health?
Answer as to whether seizures themselves can influence sexual health. So some of these, again, like very few studies that have been done. We know that there's a couple medications, again, we call these things inducers, inducing medications. So that's like things like carbamazepine is the one that was in our little piece. That one does, for some reason, and the women who do have sexual dysfunction, that medication seems to be a common scenario, a common medication that they're on. So there's a question mark that maybe that some of these features like carbamazepine might influence sexual health. Not clear exactly why that is. Maybe it is affecting downstream hormones, since, like they said, these change our hormone levels sometimes. But again, it's not something that would just, the response, if you were to tell your epilepsy doctor, you're having medicine and you're having some decreasing person sex, you were to mention this to them, our response wouldn't be to check hormone levels, because again, there's not really a good normal for them. It would probably just be a conversation about, well, you've been on medication for a long time, but we can't find any other reason for this. Could we possibly switch this to something else? Is that safe? Is that a good idea? That's a conversation, but again, it's not like a 100% known entity that causes a problem, so it just have to be thought about, discussed about. It seems like when we were discussing it at these on our journal club, very few physicians have felt comfortable asking about this, so it's just not coming up. There was, I think, one study from another academic institution where they just surveyed how often people with epilepsy were being asked about this topic, and it was very small. It was like, I was actually surprised. It might have been like 15 to 20%, which I thought was high. But it's very little. There's very little conversation about this in general, so it's not. If you feel comfortable, then it's definitely something to raise the question about and ask about, you might end up getting quite a lot of neurologists or epilepsy doctors. They might kind of end up telling me that I just talk about it a bit of but at least something will be out there. I think I might just ran into the next question about you.
Can I also ask, why are doctors about sexual health?
A very good question. I do wonder, I think with same-sex provider and patient, it can be more comfortable. That's what we heard from our male colleague, my male patients are mentioning it. And he flat out was like, I don't know how I exactly bring that up with the female patient. So I think there is some discomfort on provider end of just like not knowing if it's appropriate and like it makes them comfortable because they just aren't talking about it a lot. I will say that probably with, us and other epilepsy doctors who are thinking a lot about birth control and pregnancy planning. Focusing on that and really talking about it, I can imagine it would feel like out of the blue almost and make some providers of it. Our male colleague was like, I don't want to feel like I don't want to feel awkward or really want her to do the same kind of thing, so I think and then someone else in that conversation, she was like, well, I don't really know what I would do with the information. Like, I think if they told me that, I wouldn't really know if it was what it was. Epilepsy is medication, it's something else entirely. I'm sure if I want to really try and get that, pull that info, because again, I might be like, oh, well, this is your own doctor. It's very lots of reasons, I suppose. But it's not very sure. It's not a. Yeah. Hi. So. Bradley asking about it. Panel. Not really good. By going to see and all that other stuff. I do feel like that's I do feel like that's a pretty natural response. But that's the thing that we've kind of been trained, like, oh, like thyroid, that is something we can easily just check and we can see if that's to blame. So I think that's probably within a lot of people's comfort zone is to try to look at or blame. So I feel like that's probably the common response.
Yeah, I think, as Regan mentioned, it's a very complex topic. It's kind of like the chicken or the egg in very simple ways. Is that what is causing? Look for an organic cause for things like, hypothyroidism. So we always start with the basic common causes, but then it comes always down to, is this related to the epilepsy? And I think it is very hard to answer that. And also, even if there is, an association, which I do believe there must be an association with that, like how do you treat that? Is that more of the psychological component of the epilepsy? Is it the epilepsy itself? Is it the medication? Is everything involved? It's a very hard thing to decipher and also treat. And I think that it may leave a lot of patients, unsatisfied with that. So I think that maybe why providers may not might not ask that question, and also patients kind of feel, a lot of other barriers that make them. So it remains an undiscussed and open topic. Yeah.
Question. Earlier you said that all the jobs real effort now like pro yeah. I still think multiple figures and the take over their brain surgery and take care of it. I'm very curious to know that like what percent of the capacity that form of the treatment one cancer that I'm very curious to mine like that not it but first one, the mention that women with Catalonian epilepsy are more likely refractory. It's an assumption because those are the patients we end up seeing, but whether they are now seizure free, they're not even investigated. I think among patients with refractory epilepsy, that's a question that should come to mind for all providers and not be dismissed like, oh, she's a woman, she gets everything on her menstruation. That's not true. You should really advocate for yourself. You should notice a correlation, complete your doctor, keep a diary, and show them the correlation between that they cannot turn you off. Because I've seen a lot of patients that they've been dismissed, and then they go on a hormone. That's a great question, and we really don't have studies. We don't, other than the progesterone study that Dr. Arfaraj mentioned earlier, there's no techniques we employ for Catalonian epilepsy to know for sure what's the benefit of this. So that's much needed. I tried a couple of times for this, and I used to give me the money to do it, and I didn't think that it's worth it. Novel enough that the half of the women with epilepsy may have a Catalonian pattern. So hopefully there's more that's going to be done in the future, especially now with the White House initiative to fund women's research. We hope we'll have even more questions in the future.
That's fine. Yeah, when you guys were talking about the hormone part, when I came, one of the things that I was hoping to have answered was if anybody has ever noticed a pattern about women possibly starting to have epilepsy in their teenage years. Because I had an injury when I was an infant, when all the way through my childhood was no seizures, and when I started my period, when I was a teenager, that's when my seizure started. So that's why I had always just thought, well, maybe it was the increase in estrogen. But that's the thing. It's like if I was going to have seizures my entire life because of the brain injury, which is where the neurologist said that's where the seizures are coming from, was from the injury. Why didn't I have seizures my entire life? But they waited until I started my period to have it. So I didn't know if that was common in any way, or if that just to be me.
It's definitely a thing. We definitely see that. I want to use no, I don't know what exact percentage of that or how common it is. But that is definitely a story I've heard many times. So I think we have, all of us have a lot of questions around when these big clinical shifts are happening. So in our view, when the menstruation first starts, that's a huge, obviously, hormonal shift for the body, and then other stuff. And we're all adult epileptologists, so we're not seeing, young women get the anxiety later. So we don't have as much of a first-hand experience of as it's happening with people, 12, 13, but we we want to, we don't always, but we often try to ask, what age, how old are you? And you're just curious. It's trying to talk about this more later, but yeah, this timing of menstruation plus the second one is huge question marks on how much like most seizures and epilepsy.
Stop the first period. I would really, do you know what I mean? Could you be expecting before you see it?
Yeah. It would be really close to the time right around initial menstruation because I wouldn't think like 2 years, 3 years, I would not think that would be influencing stuff. It just really feel that time right around, like same, right around the same time. So pretty tiny amount. Yeah. That's like patients who linked the time of the student, like they volunteer that information media. That's my experience is that as soon as I started to have my period, I started to have seizures. I think rarely do they associate the years later. So
I just had one additional one since I got late. I just kind of wanted to say, since people are so hesitant to talk about the interest in sex and stuff, never had it. And I didn't know if it was the medication since I started taking it right as I was a teenager, you know, so right when you would start to have that feeling, never had it. So I've been on medication my entire life. So that's why I didn't know if there was the connection there, but it looks like there is that possibility. And like you guys were saying, that the doctors are too afraid to ask. And it's like, well, they just give a questionnaire with all the other questions. So just figured I would throw that out there as one of those pieces of data as well.
I have no idea this is for the really difficult to discuss what that patient's doing around that. That would be
Yeah, think about, which I'm probably quite alone. My sister, she developed epilepsy when she was 15 years old. The background is that when she was 9 months old, she got meningitis, an infection in the brain that developed nerve and in the brain. So it stayed since 9 months old. And all of a sudden, she's got this huge seizure. So she got a normal, focalized, and the temporal lobe. And at the same time, her behavior changed. And at that time, I'm talking about so many years ago, 13 years ago, now she's 16. We look at this literature that describe this epilepsy syndrome with the 3H, hyperphagia in the blood, hypersexuality, and hyperaggressivity. So this is many years ago. I don't know if you have any information about that. This was already ruled out. It doesn't run anymore. Because I see some questions about the sexual concerns, and I think it's very valid because everybody has, the right to enjoy their sexual life. And if there's any concerns, I was wondering why it's not a template. Usually when I go to the doctors, they have a bunch of questions and just throw it. If how's my sexual life, I wouldn't have any problem. And if it can even go, whether you want to respond or not, because nothing is mandatory, right? So, but then the physicians, they just give a good gist of this information, whether it applies to this consumer or not. But again, going back to my, to what she was saying, that she got this when she got the first menstrual period, that happens to my sister. And hopefully now with menopause, this declines.
she's still going with seizures, and the very bad side effect of the medication is that she developed cataracts and she went blind. So side effects of many, usually they use carbamazepine and tegretol at that time. And when she was 13 years old, the only thing they got was Vanagan, and you have to put an IV. And but again, in my country, healthcare is very bad. Politicians don't care too much about that. And it's time to advocate more, and hopefully you guys will have to privilege in this country. Although we would like to have good care system and healthcare. I'm not speaking for myself, but for many others who may not have access, especially in the communities with minorities who don't. I know people who speak Spanish, especially coming from that minority, they have no clue. They kind of disregard the child concerns and behavior when they have some kind of epilepsy or seizure syndrome.
I want to thank all of you for your comments so far, because the more everyone did, say, hey, everyone's saying this, so we can do it. So it's really great. Right, I really agree with it. I wanted to say one other thing. I'm just thinking about the epilepsy and sexuality. There have been a couple of reports where when there's a focus in one of the temporal lobes, and now I can't remember if it's dominant or dominant side. There have been case reports of people with temporal epilepsy. So there actually can be hypersexuality, and so that has been reported. That seems to be less common, just the flip side, which is having a lower interest. But that has been reported. You're hitting a lot of emotional centers in the temporal lobes sometimes, and it just seems like in certain spots, in certain people, it can actually create hypersexuality. And some people have noticed after temporal lobe resection that has gone away. Some people's hyposexuality after temporal lobe epilepsy surgery can show that there's a value to restored. So, parts of with the epilepsy and sexuality, it's very.
Because I wanted to add that it's also from the structures that are responsible in allowing us to experience pleasure. But on the other hand, we are playing transmitters with the chemicals in our brain. And for example, antidepressants, which play with serotonin, are known to have an impact on sexual function. I think with anti-seizure medications, we are playing with several other neurotransmitters, which precisely or what combination, when we change it in one direction or another, it influences this. Coming from the patient, to present it to the big epilepsy conferences that we have annually, where there are research, they stand there to get inspired for what to pursue next. That's the way to go as a future. We'll know more, and the pharmaceutical companies may be more aware about those potential side effects and treat their medications the right way. It all starts with you, actually. Any sort of progress for your care starts with patients voicing out those problems. We can move on to the next one.
Yeah.
Maybe we're just do something else.
Yes. We have a question, right?
For sexuality is very. Other conditions that can coexist with epilepsy, like anxiety, depression, can influence sexual function as well. And certain medications and uncontrolled seizures may affect sexual function. Not all neurology or epilepsy doctors may know how to ask about sexual health, and it's important to mention if you are concerned. So our next topic is IVF and epilepsy. Case is a 34-year-old woman with on abortion. She wants to become pregnant, and she and her partners have been actively trying for a pregnancy for close to 12 months. She has regular menstrual cycles, has been off birth control for 1 year, and has never been pregnant before. She was referred to a reproductive endocrinologist. I think it would be a good option for her. So the question is, do women with epilepsy have a harder time getting pregnant?
Historically, it was believed that women, for various reasons, hormonal changes, seizures affecting their neuroendocrine centers, medication that can actually cause menstrual irregularities, like polycystic ovarian syndrome, and all of that is attributed to the causing lower fertility. But as we're doing more studies, we're actually finding out that their ability to get pregnant is very similar to women without epilepsy. So
I would add one thing. I think the study that Dr. is referring to is called people and read about it online. That were on medications that are not enzyme inducing. So we really don't know. I think there's still a little bit of a question as to whether enzyme may lower. We can't guarantee it doesn't, but overall, we have a lot of patients in our practice on enzyme-inducing medications. And this study found that there was no difference between control patients, women that were not on medication, with epilepsy on medications,